Good day. This is Russell Hendrickson. I'm the CEO here at Practical Data Solutions. Thank you for joining us for today's webinar, Effectively Communicating Physician Compensation with Visual Analytics. I'm pleased to have joining me today Becky Cook. Becky Cook is an executive consultant with PDS. I first had the pleasure of working with her almost 15 years ago. And recently, before she became a consultant, she was a CFO of a very large health system down in Texas. Thank you for joining us today, Becky.
Thank you, Russell, for inviting me to participate. So, Russell, why don't you show us what you've got for visualization?
So, if you've attended some of our webinars in the past, I always like to start with where might you go with technology? What are people doing today? And this is a fairly sophisticated visualization that's looking at physician comp. As you can see across the left panel here, we have both paid out compensation versus earned compensation. And I can point and click. This is a fully interactive visualization. And in addition, I can look and see either which physicians or departments are having trouble with some of their incentive pools, where physicians might be earning what their salaries are. You'll notice we're using sort of targets and thresholds to identify our top performers, both in terms of earned compensation. And of course, as you can see on the bottom of this screen, we also have things like patient satisfaction, clinic goals. Now, this is a set of technology, but today's webinar really is what we want to talk about, which is how might we use compensation to specifically focus the physician on where they're not hitting their goals? And what are some of the tips and things that we've learned in helping our customers over the years that might be useful to you in today's webinars? Before we dig into how we might present compensation, I think it's important to understand what's going on in healthcare and how that's impacting compensation. So, Becky, do you want to speak to that?
Contracting is changing rapidly in the last couple of years. The Medicare Shared Savings Program has really pushed many of the commercial carriers into shared savings programs and other types of incentive plans or shared savings type plans. So we've moved significantly from volume through the areas and edges of value contracting and population health management. As we move and continue to see more and more plans moving toward managing total cost of care and reducing cost, that drives the need for changes in our compensation plan. And many of these new metrics that are needed lend themselves well to putting them on the compensation sheet along with the calculations of compensation. So some of the metrics that may need to be on your compensation sheet include things like the quality performance metrics, the Medicare Advantage plan stars performance, panel size, and direct with employer plans are exceedingly concerned with the total cost of care and making sure that these new plans generate savings for the employers. So putting these metrics on the compensation sheet as drivers of compensation is very important.
So one of the things that I hear when I speak with our customers, I don't know too many organizations that aren't thinking about changing compensation, or they might be actively changing compensation. Of course, there's a lot of challenges, and we'll talk a little bit further about when you're changing compensation and how you might visualize or communicate that. But one of the questions always is, if you're thinking about changing compensation, or if you're not, the question is, have your dashboards, have your reports, or what you're communicating with physicians, or what the department administrators are using, have they kept up with the changes in healthcare, right? And so there's a challenge to that because there's a lot of different components to compensation. Most organizations that we speak to are still very time-consuming to calculate compensation because it's done by hand. In many cases, there's very little automation. There can be a lot of errors in calculating comp, and there can be whole teams that do nothing but calculate comp. And it can be very challenging to consider making changes, even if it's just to visualize how a physician is performing. But those are some of the challenges that we see in thinking about refreshing or updating dashboards and reports.
So one of the things that is always harrowing to administrators or to a CFO is that notion around error prone. As much as we were trying to use templates and standardize the calculations for our accounting staff around monthly compensation, it seemed like there were errors that just always crept in. Someone would override a formula in a cell, not realizing that it messed up other calculations in the spreadsheets. At one point, I think the worst one I ever encountered was standing in front of a group of 35 cardiologists. And there was one cell in one of the physician's compensation sheets that was incorrect. And of course, it happened to be that he was the loudest of the complainers in the group, and he stood up in the middle of the meeting and called attention to this little math error. And it just really damaged the credibility of the entire presentation, and the physician leader was just livid when we finished. And of course, it was very easily fixed, but very unfortunate when you have things like that happen. And for all that we were trying to do to eliminate these errors, it just wasn't possible because there were so many manual calculations.
So as we think about changing our dashboards and using dashboards to better help physicians guide their performance, obviously quality, right, has got to be key, that we can be sure that the tools we're using, the ways that we're publishing data, how we're communicating, right, without effective and quality behind them really kind of deteriorates, right, the messaging that you're trying to send. So Becky, let's talk about how can dashboards be used, though, to better communicate physician comp and help physicians better self-manage their performance and the goals that are set up for them.
I think the two biggest areas that I think about when I'm working with a compensation plan and with presenting that information to the physicians is what content needs to be included and what actions am I trying to make occur. Whether it's behavior change from the physicians or physician recruiting or trying to retain a physician or just improving overall physician satisfaction with transparency makes a difference in how I'm going to present that data to the physician. And then content, there's so many different things that can be included that it can be overwhelming. We want to provide appropriate context, and you have to provide the calculation. But then trying to determine what of these other types of components should be included is quite challenging. You can get a lot of information, a spreadsheet, lots of numbers, lots of words, and it just becomes overwhelming and the physicians don't read it. So that's one of the big reasons I think that we're looking at moving to visualization, is that you can put more information on a dashboard, but with less complexity by using graphs and outlines.
And I really think that is a key. When you're designing dashboards, let's take a look at a dashboard here. It's providing enough detail so the user can understand the calculations, but providing too much detail, the user can get lost. This is a standard, kind of one of the more popular physician compensation dashboards that is in the PDS library. For those of you who are PDS customers, this is available as part of the PDS- application. And this design template is fairly easy to follow. It shows what the plan summary is. We have productivity information, which makes up the bulk of compensation. You can see there's incentive and pool and a clinical, and then the earned compensation. Becky, can you break down the design of this report a little bit and talk about what you refer to as blocks and why those are important in this design?
Well, when you look at a sheet like this with a lot of different calculations on it, it's easy to get lost. So what we've done is we've thought about the information that needs to be presented, and we've put it in little squares of information and divided them with white space and with colored markers to try and make it easier for the physicians to read or the administrators to read. Your eye can follow across the page using those broad colored lines, and hopefully you can get to the bottom and see the actual calculation. And then the most important block, I think, on this entire dashboard is the one in the lower right that shows actual compensation compared to available compensation. So this one provides the physician with a visual check on where are they not getting all of the compensation that they might be entitled to, and what do they need to do to capture it. Now, this is our standard presentation, and I'd like to show you what happens when we flip this thing as if it were being presented to a physician. We're going to put the most important information for the physician at the top. We've moved that total compensation section to the top, and all of a sudden that graph that's the same size, slightly different colors, that was on the prior sheet becomes much more prominent and much more important. And that will catch the physician's eye very quickly so that they can see what is my opportunity. And looking at the numbers right below it, Where do I have opportunity to increase? And I can see there that my clinic goals, I'm not hitting my clinic goals. My work RVU production comp is in tier 3. That may be okay, but it very clearly in that little picture tells the physician about his compensation. And if he wants to move backward through the calculations, he can. And probably the summary, the plan summary at the bottom is the information that's least frequently used. So let's put it somewhere, but let's put it out of the way. So I think overall, this type of presentation reads much faster for the physician.
It's really interesting because this sample, if I go back a page here, right, I've been used to looking at this, and the design here is very much A, right, what do we need to do? B, what are the pieces that we're doing? And then C, how does that calculate out, right? What's interesting, though, is as soon as you change that to what did we earn and what are we missing, right? So to your point, Becky, this jumps right out at me that there's available compensation that isn't being earned, and it's because we're missing some of these clinic goals. So here's the what did we do, and then here's the why, and then how do we get there? And so in my mind, I feel like we're sort of A or B, but clearly for somebody new, right, this kind of ABC helps them follow what's going on. But to your point, this just, I think, so clearly illustrates how a focused design that really gets to the heart of what they need to know be very effective once they're comfortable with their plan and looking at their reports. So even that design might need to change from when you started to 3 or 6 months later once the physicians are used to looking at the same information.
And as the plan changes over time, it's easy to replace these little blocks of information with updated plan information. So if the incentive pool changes or the clinic goals change, you don't have to redo your entire spreadsheet or your entire template. All you have to do is drop in a new piece of the plan. Very easy to maintain.
Very nice layout. So that dashboard, as much as it is a dashboard and it explains, it doesn't have a lot of graphics or visual content. So let's look at a dashboard. This is another one of the sort of standard templates in the PDS library that our customers are working with. And this is, we call this the physician KPI. So it has sort of key performance indicators. We've taken a very simple summarized approach to showing the comp. So potentially the physicians are comfortable with the plan, or we might have supporting glossary or documentation on another page. But in terms of a dashboard, very quickly I can see what I've earned, how much I've earned in bonus, and then how much is due to me as a physician. But below we have sort of tried to limit it to 5 or 6 key points, things like productivity RVUs, billing lag, coding curves, the physician-related denials, scheduling volume, and even patient satisfaction. Now we're using a lot of different points here. We're looking at 6 months average, last month, current month. We have that stoplight, red, yellow, green. So very quickly we can see in the current month we're missing our patient sat goal. But overall, last month we were doing great, and overall we're sort of, performing well. So that maybe is less of a concern. So by giving the 3 comparative points, and then we're also using either benchmarks, internal or external, or targets or thresholds for the organization. So a fairly easy way to see the supporting factors that really the physician needs to drive their productivity.
So Russell, I think we've got good use of context here. It's important for the physicians to know where they rank or how their productivity ranks comparison to other physicians, whether it be a benchmark or peer-to-peer comparisons, to give them some idea of their performance. Because to put just charge lag days on a graph doesn't really mean a whole lot unless you put it in the context of 90% of the physicians are able to hit less than 7 days, and you've been at 8.5 and higher. So you're down to 3.1 and you're back where the rest of the other physicians are.
Yeah, I think it really articulates that well. This is the same dashboard in a web-based visualization. So for those of you, again, many organizations still using Excel. There's nothing wrong with that, as long as you've got enough automation to ensure quality. This is a web-based visual dashboard. This happens to be built out in the MicroStrategy or the PDS Empower solution, as you can see. This dashboard, really the same sets of indicators. We're using these little push pins, red, yellow, green, that get us to really the same visual perspective. One of the advantages of doing sort of web-based dashboards is, one, the dashboard to the physician itself can be set up so that when he or she logs in, they're only seeing their data. But an administrator can log in and actually review or compare or meet with each physician and then discuss it as well. So it gives you that kind of capability. But you'll see very similar design, the salary, the bonus, the compensation due. We're using the push pins, and then because we have a little more real estate here on this page, we've added that appointments was sort of the minimum benchmark. We've added that charge lag Becky just referred to, and even the patient satisfaction, sort of setting our internal goal being 90% or higher.
So this is kind of new technology that's available that I never had access to, Russell, and I can see the distinct advantages of doing this. Being able to look at all of my physicians on a single dashboard and thumb through them without having to look at 20 or 30 pieces of paper would be a huge advantage. Being able to drill down into those work RVUs to understand why is the physician's work RVUs at such a low level.
One of the more popular points to web-based dashboarding, obviously it could be opened up on an iPad or even a mobile device. And of course, because it's fully relational in our analytics, it also gives us the capability to have the drill downs into individual detail. So if you want to allow the physicians to go further and look down at the details or down a few levels, you can bring those capabilities right to the end user.
Some of the context that were on these dashboards, use of stoplights or icon sets is really important. Making sure that your graph styles are matched to the data style. So if you're wanting to show a running trend, making sure that you've got an axis that reflects the timeline. Using formats that are easy to compare. I've seen people try to use spider charts, and they're hard to read. Use something that is instantly recognizable to your reader. The idea is to convey your information, not to see how pretty you can make your dashboard. Make sure that your benchmark or goal data is clearly defined. If you can't explain what that benchmark is, then you've kind of lost the impact of having a benchmark out there. And making sure all your data elements are defined. You notice that all of those data elements had chart titles on them. The axes were defined. If some of the terminology is going to be new to physicians, or you just want to make sure that your terminology is used consistently, then put a glossary at the end or the beginning of the dashboard for the readers to refer to.
Yeah, really useful. And I know one of our customers at one point, as they were changing some of the metrics in their dashboards, they added a glossary page to the first page that not only included kind of simple definitions of what they would see when they open the dashboard, but it included who to call for help or who to email if they had any questions. So in a larger organization where you've got physicians spread across broader geography, giving them a point of contact, making it much easier for people to ask questions in the moment, another best practice there. Let's take a look at another visual dashboard and build on some of the points that Becky just shared. This is an example of a point-based compensation plan, which many organizations are using. And if you look right through here, you can see sort of the key components of these work RVUs, panel size, and patient satisfaction to follow what Becky was sharing, right? So work RVUs is blue, that's 40% of the plan components. And then here you can see the various points awarded based on the physician's accomplishment for that period. The second component of the plan is panel size, which also happens to be 40% of the award. And then you can again see how the points roll and then their patient satisfaction. So you can see up top here, this physician has earned a total of 54.6 points, which targets them for the tier 3 on the base pay. So fairly easy, again, to tie the core calculation to what they've earned to how the various components or where they could potentially improve on their score.
So these types of point-based compensation plans, you could also call this a pool plan, where you may have multiple physicians who are pooling their compensation or where they're drawing out of a departmental salary pool. The corollary to this would be to show everyone the results of who drew how much out of the pool. If they're contributing to the pool, then everyone wants to know how they stand compared to other members. But very useful in some circumstances to have this type of a point plan.
So let's take and look at another visualization. So taking not exactly the same data here, but this is a visualization where we're showing multiple physicians, and then we're allowing an administrator who could see across a particular business unit. Maybe they're on a similar type of plan. So now we can start to see not only how is each physician earning their compensation, but how does that compare to their productivity rank using RVUs? so we can see quickly who are our sort of top earning physicians and who are potentially our lower performing physicians. A fairly simple layout, but it does allow us to do comparative points or isolate or highlight a particular physician or area. In this dashboard, when we first designed it, if you had seen it, it was too much information. And so it was a great usage where we wanted to focus the reader to the compensation, but we still wanted to provide those same supporting factors that you saw in the individual physician KPI. So in this case here, you'll see we added a second page. So as not to sort of diminish the message of how much the physician was earning or how productive they were, you could see additional breakouts where you can see their scheduling versus their utilization, the trending of their patient satisfaction. Here we did split out their full coding curves instead of just showing the 99214s, and provided a benchmark to their peers. And then you can see sort of these very simple gauges of patient goals, bumped rates, panel size, and would you recommend on the patient SAT scores. So good example where in certain cases, putting too much information, we want to provide enough to be comprehensive, but it made the original dashboard just too cluttered.
One of the components that I think makes this so useful is actually having the budget on this report as well as our stretch goal. Often it's very difficult to do those comparisons around physician comp and productivity to where are we standing against our budget and where are we going to end up at the end of the year. So as a department administrator, I would love to have this report that puts all this information onto a single dashboard for me and makes it interactive. So I can look at multiple different departments, or if I'm the CFO or a department administrator, I can look at my individual physicians and start to understand and manage the group much better.
Yeah, definitely makes it much easier to manage through when you can quickly access the information and share it. So let's talk about one area key that we started with, which is many organizations are in the middle of either designing new comp plans, changing their comp plans, rolling out new comp plans, and how can we use visual analytics and some of the things that we've just talked about when an organization is in the middle of changing compensation or even just planning to change compensation, which can create a lot of consternation within the physicians and within the organization. So what you're seeing here, this is what we call our side-by-side report. This is probably one of the most popular compensation reports that we have in the PDS dashboard library. And as you can see, it's using that block style we started with earlier that Becky mentioned. Here we have what is a simple, fairly simple productivity production plan with the idea that this is the current plan. And then over here you can see the proposed plan. It doesn't even say accepted plan, but this is the proposed plan. And so again, fairly easy to show that, hey, we're moving from this kind of revenue to a more productivity plan. There's that incentive pool with the clinic goals. And now you can side by side see under the current plan, I've earned 158, but under the new plan, I'm only going to earn 152. Well, the reasoning for that is you're missing some of the clinic incentive. The clinic isn't hitting their patient SAT goals. So some of that money is still out there to be earned, kind of pointing me to where I would need to improve or drive.
Russell, when I've changed comp plans before, well, I put a single spreadsheet together for my physician board to look at all of the physicians. Inevitably, there are thought leaders of individual physicians that they are concerned about what's going to happen to their comp. And so I do prepare these types of side-by-side spreadsheets for my physician leaders to review, and they can go through them and look at those physicians that they think are going to have the most difficult transition or who are thought leaders that they want to put on this new plan first or talk or discuss the plan with them and be able to show them individually what's going to happen to their comp. Even the physician leaders, while they're concerned about their peers, they also want to see their own. So inevitably, even though I do a summary spreadsheet, I also have to do these types of side-by-side comparisons. And we've even had to extend doing these 3 to 6 months into the new plan so that physicians are assured that they're making as much as they would have under the old plan for equivalent productivity. So very useful, but very challenging to get all of this information put together in a single spreadsheet.
Becky, did you find that when you were rolling out, whether it was a new dashboard or a new plan, was it more effective to meet with physicians in groups? Or was it more effective, potentially to do one-on-one meetings?
We really did a mixture. If we were talking general concepts, we could meet with a group. But then very quickly, we'd have to meet with individual physicians, and this is the type of data that they wanted. They wanted to see what is the impact going to be on me, and what's the proposed start date, and if my comp is going to go down, why should I accept that? And so we had to be prepared with transition plans or show how the incentive pool could make up those lost earnings, and keeping up with what was happening with our contracts, really, and assuring the physicians that the contracts that we had were driving the changes and the need for changes in compensation.
Very interesting. Yeah, I know it's a challenge working through. So if I were to summarize, it's important to review your current compensation reporting designs, make sure they're staying relevant, even if you're not changing your comp plan. You may want to consider updating your designs, making things simpler, easier to understand, or even start incorporating metrics that are key to the organization, which I know many organizations are including, some of the new quality metrics, even though they're not built into the comp plans. And of course, integrating those performance data points, helping the physicians understand how they're performing, how their peers are performing. If you're going to use external benchmarks, making sure they're appropriate and easily identified within the dashboards you're sharing.
I think it's also important to solicit feedback. What are the physicians using on the reports? What are they not using? If data is not being used, then remove it. Sometimes removing is as important as displaying something new. And I find that the physicians who understand value-based contracting and who understand the need for showing the quality metrics are really very accepting of doing some of these changes. You need to make sure that you're constantly working with your compensation plan, because healthcare contracting and healthcare plans are changing so much lately that it may be that you're going to have to start working with annual changes to your compensation plan. At a minimum, as you leave or enter new plans, you're going to have to update your comp plans. And I think a big one is making sure that you can automate wherever possible. Use of appropriate templates, use of extracting data from the various systems and making sure that you can combine it easily are very important for quality of the calculations and the presentation.
Thanks, Becky. For those of you who are PDS customers, thank you for being a PDS customer. For those of you who joined us today or are unfamiliar with PDS, thank you for joining us. We hope to see or talk with you in the future. Becky, thank you so much for sharing all the ideas and samples today. We appreciate that.
You're welcome.
Thanks, everyone. Have a wonderful day.